Assalamu alaikum. Hello everyone, it's Tonya, and today we'll be talking about the three important lectures in the geriatrics course. Of course, I'll be using the materials from our PDF lectures sent by the professors in Faculty of Medicine, Tanto University. I'll try to give this video about the three main videos I've posted before, all in English, so that it will be useful or more helpful for foreign students who are studying our faculty. So let's start with the first lecture, which is aging-related changes of respiratory system. What happens in the respiratory system when the patient or the person gets older? First of all, the chest wall. There will be changes summarized in the letters CIC. First of all, the costovertebral joint mobility decreases. Intervertebral disc spaces are narrowed, which is reflected as kyphosis or hyperkyphosis if the angle is more than 40 degrees. And finally, costal cartilage calcification. These changes will reduce the lung compliance. And when talking about compliance, we have to highlight that there are two types of compliance. First of all, lung compliance, which means the change in volume relative to change in pressure, and thoracic compliance, which is the elasticity of the lung. Both of them will decrease based on these changes in the chest wall. What happens to the intercostal muscles? We can summarize it in 3M. First of all, the maximum respiratory pressure, which decreases by 0.8 to 2.7 centimeter of water per year between the ages of 65 to 85. The second M is for muscle atrophy, especially decreased fast-twitch fibers, which result in higher peak tension. Finally, mitochondrial adenosine triphosphate decrease, which is complicated with diaphragmatic fatigue. What about the air passages? We have double C, calcification of the tracheal cartilage, and so on. The clearance of mucus decrease, especially as the cough strength is lowered and the patient is less able to cough up the mucus. Now let's check what are the changes in the lung. In the lung, there's what's called senile hyperinflation. What's meant by senile hyperinflation? We can discuss the changes into two categories. First of all, the parenchyma, and then supporting structures. Concerning the parenchyma, the stiffness increase, the posterior bicensus increase, lipofibroblasts increase, MHC1 increase, and also alveolar type 1 cells increase. All of these increase the compliance, decrease the compliance and precipitate for respiratory failure. What about supporting structures? We can summarize it in two homogeneous and two alveolar. First of all, homogeneous degeneration of elastic fibers around the alveolar duct, and then homogeneous increase in distal aerospace cross-sectional diameter, which is almost similar to emphysema. Later on, alveolar gas exchange surface area is lost, and the alveolus per capillary number decreased because the surface area of each alveoli is increased, and so on. The alveolar capillary number decreases. All of these again disrupt the gas exchange process. What about the immunological changes? The neutrophils number increase, although their function, which is chemotaxis and migration, decreases evidently. Lymphocytes number increase, although B lymphocytes and naive T cells decrease. The ratio of CD4 to CD8 in the bile fluid increase. IgM and IgA in bile fluid also increase. Ability of alveolar macrophages to release superoxide anions increase, also the total number of macrophages decrease. Memory cells increase. Total protein alpha-1 antitrypsin increase, also the antioxidant level decrease, which is relevant because ability of the alveolar macrophage to release superoxide anions increase despite the fact that the body is not able to defend itself and the antioxidant level decrease. So if these two items are not opposite, there will be no evident effect. I mean, if the superoxide anions level increased and also antioxidant level increased, the damage will be neutralized. However, the damage occurs, and that's why we have done extra studies and investigations to find out the underlying pathology. So superoxide anions increase, yet antioxidant level decrease. Vascular endothelial growth factor also decrease. And finally, we're talking about the receptors, which is an important topic to be present in our questions. The affinity of the receptors decrease, either beta adrenal receptors or muscarinic receptors, and we have to take care that the high density receptors are those ones which are affected, and the affection is in their affinity, not in their number. Moving to lecture 2, which is aging related changes of the cardiovascular system. This is our cardiovascular system, or the heart. What happens in our heart? First of all, the overall shape changes from elliptical to spheroid. And take care because this point came before in the MCQ exams. Also, there is an asymmetric increase in the interventricular septum. This image is not the most accurate image of the heart, however, it's evident. Some changes which occur in endoly are a little bit evident. As you can see here, there is asymmetric increase in the interventricular septum. Also about the aortic root, the root dilates 6% and the knob diameter increases from 3.4 to 3.8 cm. Finally, the intimal medial layer seconds 3 times. What about the left atrium? As you can see in our image, the left atrium size increased. Also, the left atrium size in elderly, the left atrium in elderly is at high risk of complication as atrial fibrillation. And atrial fibrillation is determined by the loss of the A wave. Also, there will be endometrial dysfunction, which is evident due to high oxidative stress. What about the right side? When we are moving to the right side, we'll find the SA node. Fat accumulates, causing partial or complete separation of the SA node, and also the number of the pacemaker cells decrease. As we have talking about the electrophysiology, we have to complete it and take a look at the left-sided cardiac skeleton. There will be calcification, and the PR interval will be prolonged, and also the QRS will shift leftwards. So the electrophysiology of the heart is severely affected. Completing our talking about the right side, we'll have to note that aortic valve will be calcified, and this is complicated with and clinically presented as aortic stenosis. So now we have discussed the overall shape, the aortic root, and the left atrium, the right atrium. What about the ventricles? First, let's start with the myocytes. As you can see here in this image, the number decreases, however the size of the cells increase. So the number of the cells decrease due to apoptosis, and the size increase, which is reflected as increased myocardial thickness, is evident here, that later on is complicated with heart failure. Also, there is altered calcium handling, and the myocytes can't function properly. Now, what about the function of the ventricles? Systolic or left ventricular ejection fraction is preserved unless the patient is suffering from other cardiac disease. However, if the patient is not suffering from other cardiac disease, aging per se is not related to the or doesn't affect the left ventricular ejection fraction. The diastolic function, however, is affected. E wave decreases, which means that the peak early diastolic filling is decreased, and A wave on the other hand increases, which means that there will be increased reliance on the left atrial contraction. And you can see a sequence here. First, E wave decreases, which means peak early diastolic filling and the heart doesn't empty completely or doesn't fill with blood before contraction. So this puts an extra load on the left atrium, which leads to increased E wave and increased reliance on the left atrial for contraction and increased size of the left atrium. Later on, when the left atrium loses its control or is not able anymore to function properly, it will be presented with loss of the A wave, which is complicated with atrial fibrillation. Finally, let's talk about the sympathetic nervous system. The response of beta adrenergic receptor decreases, and again we are talking about the response of the receptors, and the number is not affected. Now let's move to the vessels. We have the intima. First of all, we have a general rule to discuss in the vessels in general. Collagen increases and calcification increases, yet elastin and angiogenesis decreases. So what about intima in particular? Collagen increases as discussed, and calcification also. There will be higher reactive oxygen species. Elastin decreases as elastin fraying occurs and increased activity of elastase, and angiogenesis decreases. Before moving to the next part, we have to highlight that collagen increase because irreversible cross-linking of the collagen occurs. Endothelial cell census occurs, and there is increased vasoconstrictors as endothelin and angiotensin II, and take care that angiotensin II local levels are higher than circulating levels, and also vasodilators will decrease as nitric oxide synthase decrease, which reduces the nitric oxide levels. What about intima media or vascular media? Again, collagen increases, calcification increase, elastin decrease. However, the affected cell or the responsible cell in the intima media is vasomotor cell. Vasomotor cell census occurs and hypertrophy. What about the adventitia? We can say many details about the adventitia. However, we can stick to our basic, which is increased collagen and decreased elastin and increased inflammation. Other items can be mentioned, such as increased fibronectin and increased proteoglycan. However, in our lectures, the professor only mentioned that there will be increased collagen and decreased elastin with increased inflammatory cells. Now, let's move to the final lecture, which is pharmacological changes in elderly. Pharmacological changes in elderly, some features are decreased, some features are preserved, and some features are increased. The only feature which is preserved in our lecture is P450 enzymes. They are preserved. So any drugs which are concerned or related to the P450 enzymes, their metabolism or distribution in the body will not be affected. However, other things are decreased and other things are increased. The things that are increased are two boxes, and we will leave these two boxes as clues that we will discover later on. The features that will decrease, however, are two only, also absorption and distribution and metabolism and clearance. First, let's start with the absorption and distribution. We have 3 G's, 2 P's, M and W. G, gastric emptying decreases, gut transition is slower, and both of these lead to greater absorption over a longer time as the drugs stay for a longer period in the GIT system. The last G is for gastric acid secretion, which decreases. This affects mainly the drugs that have a free capsule, because these drugs require certain pH for the free capsule to be liberated and the drug to be released out of the capsule. So the affection of the gastric acid affects these category of drugs. We also have to note that the gastric acid secretion, although it's decreased physiologically in elderly, also patients who are elderly are frequently taking proton pump inhibitors, which further dysregulates gastric acid secretion. Let's start with the P's. First P is poor circulation, which means there will be decreased transcutaneous absorption, and the second P is protein binding or albumin, which decreases. When albumin decreases, there will be increased free fraction of albumin-bound drugs, which means that there might be increased toxicity by certain drugs. M for muscle mass or lean body mass, which decreases. This expectedly decreases or makes the intramuscular absorption erratic. However, it also results in inaccurate predictive equations in which the lean body mass will be exaggerated. For the W, the water content of the body will decrease, which means there will be decreased volume of distribution for hydrophilic drugs because these drugs dissolve in water. Talking about the water content and hydrophilic drugs will unlock the first clue in our yellow boxes, which are the increased features, which is the fat. Fat content in the body increases in contrary to the water content of the body, and this in result increases the volume distribution of lipophilic drugs, also in contrast to the decreased distribution of the hydrophilic drugs. Now we have talked about the preserved features. In the increased features, we've only talked about the fat absorption, and there is a still unlocked box. And in the decreased feature, of talking about absorption and distribution. Now let's move to the metabolism and clearance. Metabolism and clearance, we will start first by general factors about metabolism. When first pass metabolism decreases, and this consequently leads to the increased oral bioavailability, and this item is very important because it came before in one of the MCQ questions. Metabolic substrate decrease, and this is mainly concerned with paracetamol because glutathione decreases, and this affects paracetamol metabolism. For the liver, everything almost decreases. Liver mass decreases, hepatic blood flow decreases, and this results in decreased drugs with high hepatic extraction ratio in systemic circulation, and also hepatic clearance rate decreases, which result in decreased number of CYP enzymes by almost 30%. For the kidney, also everything decreases, glomerular filtration rate decreases, and this mainly affects water-soluble drugs and decreases its clearance. And finally, tubular excretion decreases, which affects mainly beta-lactams. Now, we only have the last yellow box to finish our lecture. So what increases, it's mainly related to some drugs. So the toxicity of some drugs increase, which is mainly nephrotoxic drugs. Nephrotoxic drugs in elderly are at more risk of causing toxicity than other drugs. Increased sensitivity of opiates by 50%, and increased CNS depressants such as propofol sensitivity. Some important drugs side effects are more exaggerated or reflected in elderly, as anticholinergic side effects of tricyclic antidepressants are increased, such as constipation and delirium. And this is also another important item because it came before in MCQ questions. The adverse events of anticoagulants are increased, and there will be increased frequency of bleeding. Negative inotrope side effects as verapamil and diltiazem are exaggerated, as bradyarrhythmia and hypotension, and one of the questions before asked about hypotension. Finally, there will be increased penetration of the blood-brain barrier. Why? Because there will be age-related decline in the function of R-glycoprotein efflux pump, which allows the drugs to cross the blood-brain barrier with higher rate. So thank you all. I hope this has been helpful as much as possible. Looking forward to seeing you in other videos.